colleague and teammate. Her name is Dr. Diana Wangari. She's our in-house resident doctor at Nation. And as you may have noticed, her voice is one term, so I'm really trying to to help her a bit. Huh? So thank you so much, ladies and gentlemen. For us as journalists, it's always a blessing to learn so much from you. We first will love to go through a round of introductions. I know there are people who have entered a while ago, and they're wondering who's this gray-bearded man seated over here. So thank you. Let's start with you, sir.
I am C.T. Muga. I am a research scientist, but I am also a broadcast journalist.
Good morning, everyone. I'm Dr. Rose Bosire, a research scientist at SCEMRI, representing the DG.
Good morning. Dr. Supa Tunje, a pediatrician and neurologist, Machakos County, and the president of Kenya Pediatric Association.
Good morning. Vincent Kagonya is my name. I'm a health systems researcher at KEMRI Wellcome Trust.
Good morning. I'm Fred Were. I teach at the University of Nairobi. Students are doubting. But in addition, I am the head of the Kenya Pediatric Research Consortium, which is part of the organization that was working on this research.
Good morning. I'm Dr. Edna Mutua, a social scientist working at the KEMRI Wellcome Trust.
Good morning. My name is Dr. Dorothy Olwach. I'm also a social scientist working for the KEMRI Wellcome Trust Research Program.
Good morning. David Gadara, an assistant professor in health systems and intermediate research fellow at the KEMRI Wellcome Trust and lead nursing workforce research.
Good morning. My name is Dr. Meshuki Maina, a pediatrician and a clinical researcher at the KEMRI Wellcome Trust Research Program. Thank you.
Thank you so much. It's always a blessing to have scientists, researchers, journalists on the panel, because they're going to break it into very palatable bits as to why we are here for those who are watching and also who may just have joined in. Siti, will you do the honors?
He was whispering because I'd asked him, what do you want me to say? Then he told me he wants me to tell you why we are here. The process of starting, curating, and ensuring that a research project takes place often takes time, and the background work is never quite seen. The time you interact with the research project is when the researchers actually go into the field and start gathering information, or the field may be a hospital, as in this case. That's when you get to know about them. But a lot takes place. Now, why we have research is because we want to answer a question, really. There's something we don't fully understand, and we want to understand what it's all about. So we go through this process of creating a protocol, which then goes into the details of what we're going to do and how we're going to do it and with whom we're going to do it and the duration of time it's going to take. Now, all these things are because research that involves human beings are guided by research ethics. And there are certain things you cannot do and there are certain things you can do. And for people to understand it, it must be written down. Because the thing about research is, if it isn't written down, it didn't happen. If it isn't documented, it didn't happen. This isn't one of those situations where you and your 10 best friends come to a conclusion that the earth is actually square. And you've convinced each other and everybody knows it is square. It isn't one of those. This one, it has to be evidence-based. And the process that was undertaken in this ethnographic study is what this particular meeting is about. Before you start a study, you inform those with whom you're going to work of what you're going to do. But you also inform them that at the end of the study, you'll come back and tell them what your findings were with regards to what it is you're doing. This is one such session when you're being told that process that was undertaken came to an end, and the results that we came up with were as follows. And that's why you find this array of people here who in their own way will inform you in detail what it is that was done, how it was done, and what it is that it leads to, and how that is going to help us formulate a proper and valuable way forward.
Thank you so much, Siti. Now, I would wish to open the floor to any questions. You've attended presentations. Perhaps Dr. Diana can start from that end.
Yes, we have a lovely lady here.
Yes.
She has a burning question.
Thank you.
I have been volunteered. I don't think I have a burning question, but my name is Anne Kirema. I'm a registered nurse, and at the moment working at the Healthcare Quality Division at Kenyatta National Hospital. I am happy to hear us discussing things that matter. What matters? What matters to the patient and what matters to the healthcare worker? And of course, we are also discussing about the soft skills. We're talking about what do we do so that we get better outcomes for our patients. My question goes to my friend Gadara. You've talked about what affects the care that nurses give. There are many factors. One is the ratio of nurse to patient, skills and knowledge. And then, of course, even the hours the nurse puts into this care. Sometimes we've had people change policy and say, let us change the hours the nurses take in a shift so that we can cover shortage. Do you think that affects the outcome? And also, does it affect even the soft skills, for example? Are we able to communicate? If we overstretch this nurse for 12 hours, will they be able to talk to the mother well? Will they be able to talk to even their colleagues well and hand over work from one shift to the next? So I would like us to, I don't know whether in the study we thought about the hours that the nurse, how much can we stretch a nurse to? The NBU is a high level risky and very stressful unit. Because a mistake, one thing can trip to one end. You can be going up, getting to a better place, and then the next minute we're on the other end. I think we need to also advise the policy makers, the decision makers, that please do not interfere. How far can you get? For example, saying a nurse in an NBU to do 12-hour shift. I think that is just suicidal to me as a nurse, and it is not going to help even the babies that we are talking about. Let us hear, maybe even if we have not done the study, and see whether we can get further and say, this is how far a nurse can go. Thank you.
Thank you for that. You know what I've realized? We have started the session, and there are viewers, listeners as well, who might not know what's happening. So I'd want Mishuki, Prof, just a quick overview. Prof, to start, just a quick overview, not why we're here, but what is the study. Then I'll turn it over to Mishuki before you respond.
The one thing at the beginning. Good morning again. Still morning, I think, heading to afternoon. Yes, the study. I'll give a schematic diagram of it, and then Ishiki will outline a bit more. We have all been aware that the newborn health outcomes are not as good in this country as we want them. We aim to make sure we reach a level of loss of newborns less than 12 per 1,000 live births, and we are not on the way there. And us researchers have an obligation to see which ways are available to us that we can advise the Ministry of Health and the Department of Health in the counties on how to make us win that battle. We know that everything will be around the 6 building blocks of health systems. But we also know that one of the pivotal ones is human resources for health. And this work was around how do we perfect the people whom we entrust with looking after those newborns, because many of them are born in hospitals or get there to do the best they can within the environment that they are in. So this work was about largely nurses who are the pivotal carers of the newborn. And if we don't win that one, our dream of reaching less than 12, I would like it to be talking about less than 10, not 12 per 1,000 live births, will not be met. I think beyond that, let me permit Mishuki to say a bit more of the simplified hard science that he did.
Good morning, everyone. So I'll just give you a brief overview of the project. The project is commonly referred to as HiQ, Learning to Harness Innovations in Global Health for Quality Care. And so our main objective was to learn how human resource, and in this case, in the newborn unit, nursing workforce and technologies. Many of our facilities in the Kenyan hospitals now are recipients of many technologies, incubators, machines to help the babies breathe better, to keep them warm, to treat conditions like jaundice. And so to ask ourselves, how can we better equip these units in terms of human resource to provide quality care? And so what we did is in 4 public neonatal units, we added extra workforce, that's nurses, trained, registered Kenyan nurses, into the already existing workforce into these facilities for a duration of 15 months. Integrated into the normal routines, the normal shift that the hospital has for 15 months. Over and above that intervention, we added 3 extra ward assistants, and the thinking was for the ward assistant to work under the supervision of the nurse to really help the nurse in some tasks that are not highly skilled tasks. For example, moving a file from the ward to maybe the finance department, picking up a box of pharmaceuticals or drugs, maybe from the pharmacy to the ward, cleaning some of the maybe cups or materials that are being used in the ward. And the thinking was if this time is available for the nurse, is freed up for the nurse is going to provide care. And so what we found from our work were 3 main things that we want to highlight. Number one is that out of the care that a baby needs during their course of care in a 12-hour shift, what we found is about 70% of this care is actually provided either by the nurse with the assistance of the mother or the students. 70% of the care is provided, but about 30% of the care is actually missed or left undone. Second thing we observed is the serious time constraints that the nurse has to provide care. And so we found a nurse has about 30 to 35 minutes in a 12-hour shift to take care of a baby. This is way below the global standards, where a nurse has maybe 5 to 6 hours in a 12-hour shift to take care of this particular baby. But the third thing we found out is the emotional burden and stress that these units have for the mothers. New environment, taking care of sick babies with limited support and limited communication, and that is a high stress level, environment for the mothers. But also for the healthcare providers, in this case the nurse is overwhelmed. Many babies to take care of, maybe one nurse taking care of even 20 to 25 babies in a shift. Overstretched, can only do so much, very little time to take a break or even just a cup of tea. And so these are some of the things that we found. But also what we've learned is some of these units were built a long time ago, and so the layout is really not conducive for the number of babies that are receiving care in these units. Thank you.
Back to the burning question.
Thank you. So responding to the question on whether, we should consider extending nursing shifts to, having 12-hour shifts, or from shorter to longer shifts. The answer to that question is two-pronged. One is, what are we trying to achieve? Are we trying to achieve access to nursing care? Because I think so we're trying not to address the problem. The problem is we don't have enough nurses, and just extending the number of hours really doesn't address that problem, because you're just allowing a nurse to have longer periods of time with limited work. So you have limited workforce over extended periods of time. So what you're improving is access to nursing care rather than access or coverage with quality nursing care, which is what will make a difference. So I think we need first to recognize that and communicate that to the leadership that's what's needed. I think the second one is, I think it's really unfair that in healthcare, we really don't have regulation. In this country, truck drivers have a number of hours they can drive. Truck drivers. But we don't have a regulation that says nurses or doctors cannot work an X number of hours without rest, or an X number of hours continuously. So really is, maybe it's time in healthcare we repackaged what we do and say, if you really expose me for 2 straight shifts for 12 hours, people die, and people pay the price for that, and we need a regulation around that. Thank you.
Thank you so much. Remember, for the viewers who are watching at home, you can pose your questions via all our social media platforms at NTV Kenya, be it TikTok, be it Facebook, be it Twitter or X, and the panel here will be able to answer all your questions. Now, talking of questions in the comment section, I've been following. I can see there's someone who wants to know and is asking, does the experiences vary in rural and urban settings? So I don't know what our researchers have to say about that. I mean, what they want to understand is, what did you observe about neonatal nurses in mashinani vis-a-vis in urban centers? Thank you.
Okay. So generally, I think we covered largely urban, semi-urban, and rural facilities. But the general observation is that the same reasons that cause to the stresses within the health systems, I think, cut across all hospitals. And what am I driving at is that the experiences were sort of similar across the different hospitals and different regions. So for the nurses, the burnout issues, high workloads, shortages of supplies, cuts across all hospitals. For the mothers, I think it's the same, gaps in communication and limitation in terms of social support that they get within the hospitals. But quite important to also acknowledge that people come from different backgrounds, different settings, different ages. So different populations subjected to different levels of needs and vulnerabilities, which might be the same experience or the same thing that they're going through, but the extent of that is impacting on their well-being might differ. A good example, when you talk about younger mothers, for example, and early pregnancies, so they come already to the newborn unit or the hospital, they're already facing stigma and a different challenge, different to a mom, for example, who's had several pregnancies with some experience in terms of how to care for the baby, how to breastfeed. So they come in with different bases and platforms, which has got an implication on the experiences within the newborn unit. Thanks.
Thank you so much. Now, an interesting aspect of your study touches on the fact that one nurse takes care of around 25 babies. And I'm left wondering, because there are health institutions that even have only 2 neonatal nurses within a 24-hour shift. And these are human beings. They work back to back. Some of these facilities, if not most of them, do not have baby formula. I have been in health facilities where I've seen the same neonatal nurses contribute out of pocket their meager salaries just to afford these provisions that the government cannot provide. Now, I would want you to speak to this human being, this person we fondly call the neonatal nurse. What, in summary, should we do to take care of them? If, let's say, the health CS Adendwale called you in a room right now, what would you tell him as our researchers?
Yeah, thank you for that. And I think there are a couple of things. One is on addressing the question about numbers that we've been talking about. I think you've given an average situation of 20 to 25. That's the best case scenario that we have in the country. And currently we know for sure with attrition and transitions, people going on retirement, there's a challenge when it comes to how we manage transition, how many people are retiring, how many are resigning from service. And therefore the replacement rate is also not matching the rate at which people are leaving the turnover rate. Yeah? So if we're talking about 2025, then the number even goes even higher to 30, 40, or even more. So there's a question about numbers. So first of all, supply demand we need to be addressed. There's a lot of supply in terms of training and graduation coming along, but the absorption into the system does not match that to match the rate at which the turnovers are happening, but also in terms of workload. We are experiencing a population growth as a country, and there is demand into the healthcare system in terms of services. So facilities that were constructed with a bed capacity of about 30 many years back, they're having to see even more and more babies. So that's the other question in terms of infrastructure. We applaud some counties that have taken up the mandate to do a whole wing of mother and child care, and that is in one way trying to address the infrastructure question. Secondly is the other question of the work conditions. Work conditions span from supplies. Even if we have whatever numbers we have, 1 to 20, and you don't have paracetamol, you don't have a simple antibiotic that needs to fix a baby's condition, then what much can you do in that situation? So there is also the support that needs to come from addressing the more inputs question that address issues of what tools, commodities, healthcare workers need to access in order to deliver the care that they need. And the most forgotten question that also as Kemri and the team here, we're also trying to understand is how best to support the carer, in this case, the healthcare worker, their well-being, and issues around motivation, job satisfaction, and burnout. There are things that need to be relooked at from, a zoomed-in lens, and just to unpack the monster. If the carer is not happy, if the carer is sad, you can imagine the care that they need to deliver as well. So there are a couple of things that the ministry and the Honorable CS could address, just to mention a few. Thank you.
Thank you so much. At this point, I'm tempted to ask whether Shah is working, but we'll get to that later. Anyway, there's a very special lady in this room I want to introduce. She's come all the way from Kenyatta National Hospital. Her name is Rama Abdullahi, and she's a neonatal nurse. I just want us to hear from the horse's mouth. What is a day like in your life? Thank you so much.
Thank you so much. Much appreciation goes to all our stakeholders. And I'm thanking Kenyatta National Hospital for giving me this opportunity to be here with you. And just for correction, I'm a neonatal nurse by experience, not by training. But I'm a very senior nurse in NBU, principal nursing officer, and at the moment, I'm the one who is acting as an in charge. So, first and foremost, I'm appreciating about the study, the project. I asked our moderator, sorry to point you, is this study more about only KNH newborn unit? Because I'm seeing it's speaking about KNH newborn unit. From the way I'm seeing. Then that's the time she told me, by the way, I'm requesting you to say a word to us. Then, what I'm trying to say is, yes, a day in NBU for a nurse is a tough day. First and foremost, before forgetting, Kenyatta National Hospital Management have really tried their best to bring great changes in main NBU. And my colleagues, my team members, our fellows, they're here, they can attest to it, that much has been done. Despite all that, we are having huge challenges. One of it being staff, nurse-patient ratio, and limited resources, the long duration of nurses' shift. We call it D shift in our place. There is no difference between D shift and 12-hour shift, because D shift in our place, it is 10.5, close to 11 hours. But by the time you hand over those 25 patients, my dear, you would have you would have gone beyond that time. And a good example is, I'm supposed to be as an in charge in the unit, but I chip in everything. Like yesterday is a good example. I had to leave the place at 7 p.m. just to solve problems. So what I'm trying to say is, to cut the long story short, is the day for a nurse in main NBU is quite challenging, and we need to solve that problem, to curb this problem, and thank God to the study that is going to help us much. And please don't forget about the 12-hour shift, because an NBU nurse, a good example is the nurse who is working in NICU. NICU, the nurse-patient ratio should be 1:1, but unfortunately that is not the case. Maybe we are having 7 babies who are mechanically ventilated, and the number of nurses we are getting, they are just, who is reporting on duty that day, they are just minimal. Reason being, yes, we have good number of nurses in that unit, but there are several factors which is hindering quality care. But despite all that, as NBU nurses, we are really trying our best to give good quality care to our babies. And the other factors that I want to say is, Kenyatta National Hospital is a East African National Hospital, sorry to say that. Reason being, we are getting patients from Uganda, Tanzania, all of them Kenyans, all of them, they come to main NBU. And everyone has high demand for main NBU due to the great work we give, despite all the challenges. So what I'm trying to say is, this study should bring greater changes to entire public facilities of Kenya. Thank you so much.
Round of applause for her, please. Thank you so much. Among those many challenges, I hope also at KNH we solved our generator problems. Anyway, let's go to Dr. Diana. I think we have another guest with us.
We have several voices that would want to speak and tell, again, their lived experience as well, right? Nancy, would you want to share?
Thank you so much for the opportunity to share. The question was how it's like to be newborn, how the days is like in newborn. I want to explain a very recent day, yesterday. In my unit in Kerogoya, I had 48 babies, 12 category, 1 nurse, 2 referrals to Kenyatta. The same nurse should refer to Kenyatta. So I was off because I was to arrest yesterday. So at 9 a.m., I was called. The nurse was in the ward, is overwhelmed. She doesn't know what to do. And her words were, Nancy, I'm so overwhelmed. I'm so stressed. I don't know what to do. What I did is to put on my clothes, drove to work, and I worked up to 5. And I'm supposed to travel to come to this meeting because we need to save these babies. I want to acknowledge what the county government has done. I've been there in newborn unit in Kerogoya from its genesis. I started newborn unit. We had a mischief called newborn unit, and Neonatal corner, no nurses there. Midwives would check once in a while, and babies used to die in big numbers. When I began, we started a newborn in a corridor. It was an exit corridor. We divided. And we show cause why newborn need room. I remember one doctor asking me, why do you need rooms for? Only these few babies. But within that, babies start coming in. People people are preferring public hospitals. And so the number increased. And the very few rooms, 2 rooms without this big room, became very few. So we extended, the office became a neonatal or a unit, and the other corridor also became the unit or unit. So we had 4 within a very few whatever. But because of that, partners came like Nest 360 that really helped us to renovate that unit, and the care improved. Then the county saw the need, and they built a very magnificent unit for us. But we don't have nurses. If we are to improve care, newborn care and outcomes, we need to match. It has to be a battle, not one thing and then the other. I think that's where we've missed. But newborn, the nurse in newborn, we are just crashing that nurse. It's so overwhelming. The passion is there, The skills are there. The knowledge is there. The heart to do is there. But how much can you do? Like the yesterday nurse, she asked me, what can I do? And I was like, let me come. And you have not rested for a week. And how long will that continue before I'm also crashing? Before the other one is also burning out. So the burnout is clear. And we are wondering who will speak for us? Who will speak this for the nurses? So I really appreciate and acknowledge the great work that the researchers have done and how this can be communicated for our policymakers. Because we have policies, it's not the policy, it's implementation. How can it can be taken seriously to save those babies so that we can reduce neonatal mortality. We pump machines, neonatal mortality will still go up. We build big building without staff, without nurses. We'll not see what we are looking for. So staff shortage is critical. It has never been in this where it is, that what is you asked is there somebody there? Ukona mtu, kuna nurse. And, you know, it's there. That's where we are. So nurses are burning out. And very soon, they'll burn completely.
Thank you. Round of applause. And this is just a reminder to all the men out there who are dating nurses. Please don't break their hearts. They've already had enough burnout. Anyway, thank you so much. And perhaps if you follow the nation coverage on health, you'll see we've been really prioritizing and highlighting nurses. For one reason, if you remember, in the last 2 years, I think, there has been no internships being allocated for nurses. But I think recently the health CS fixed that, which is a good thing. I'm hoping we'll train more so that they come also and help out. Diana, do we have another? Oh, thank you. Yes.
My name is Claire Mukanda, a nurse at KNH, but mine is a countrywide overview. We are talking about shortage. But KMTCs have never closed. We train nurses each and every year, they qualify. Where do these nurses go? They go to look for greener pastures. Which are the greener pastures? Why has the country failed to get the greener pastures in our own land? So unless those issues of greener pastures are addressed and captured and retained home, we are still going to have shortages. We are nurses today, we are retiring tomorrow. Who will take care of us when we have retired? Those are the gaps that we need to address. As much as you will give the feedback to the government after the project, one of the recommendations is address the nurses' issues. If we don't address our issues, we are still having the same song, come here, in and out. So shortage is not an issue to be talked about because our MTCs are open. And funny enough, if I tell you that the nursing booking is up to 2027, KMTC intake, which means we already have waiting nurses who have already finished Form 4. So I don't think it's an issue.
Interesting insights. A round of applause for her. I think it's bold to speak up. And yes, please hand over the mic to her, Diana. Thank you. Please start by introducing yourself and then your insights.
Okay, good afternoon. I'm Tabitha from Thika. I don't want to repeat what Nancy has said or Claire because they are nurses. I want to say this. Until we treat our newborn care unit as a sub-NICO, we are not going to go anywhere. We are going to talk about shortage throughout, and we are not doing anything because we have the numbers we require in our NBU, which is well stipulated by WHO, UNICEF, and so many other. And whatever we are doing, the study we are doing, we are still going to come up with another policy, which will not be implemented. Our humble request to our CS, kindly hear our prayer, hear our cry, and add more nurses in those specialized units. On top of that, Kenyatta, we have really expressed the way we have been overwhelming them. We have level 5s, where we have also trained people and those people with specialized training. We need to scale up our level 5. At least we have NICUs in several areas. We have the NICUs in Nakuru, in Dika, Machakos. We should not overwhelm the Kenyatta. We should do something. We put machines, we put those vents in those areas. People are going back to Kenyatta to train, but they are coming back underutilizing those skills. So our hub was request, add more staffing. Let us upgrade our level 5s to level 6 by adding the equipment and adding the staffing. Thank you.
Thank you very much.
That was quite something. I think just listening to the nurses in the room and going back to the researchers, there's a question that has come up specifically from the comments around, I think it was raised from Kirugoya, around the physical layout, right, of a newborn unit. And this question was quite specific, that asked, did you find what the optimal or what is the key in that physical layout? I know it's a very tough question to ask, but would you have any insights on that?
Thank you. So space and layout of NBUs is a critical issue. So from our study and our findings, what we observed was, narrow wards, overcrowded spaces, which has implications of what nurses are doing. So for example, if you're sat at the far end of the corner, and there are babies who need your attention on the other side of the corner and you're not able to see what's happening in different spaces, that becomes an issue. So thinking around how the newborn units are designed, and also spaces that can support your supportive role as a nurse. What do I mean by that? So throughout the discussion, it's been the issue of one nurse to more than 15 babies. It's not just the 15 babies, that means 15 mothers. So how do you support these 15 mothers while looking after the 15 babies as well? So from our findings, we're seeing gaps in communication and the level of support. So with the resources that we have and the layout as designed, are there things that can be done, for example, group support and group counseling sessions? So thinking about, do we have the space within our newborn unit to support such low-lying or low-fruit interventions that we can put in place? Again, touching on the mothers and the nurses is the issue of privacy in communication. I think this is a space that's highly emotional. So what happens when a mother loses a baby? As a healthcare provider, you're expected to provide some counseling or support to the mothers. Do you have the space, private space, to have that conversation with the mom? So a lot of thinking also needs to go into making sure that we have spaces that are comfortable for the moms, but also for the nurses. A critical issue is, where are the sleeping spaces for these mothers? Are they within the newborn unit or outside the newborn unit, or do they even exist in the first place? And remember, some of the mothers have delivered through C-section. So the issue of having to sometimes up a fleet of stairs and back down again every 3 to 2 hours, that becomes an emotional toil for the mothers. Again, the issue of kangaroo mother care. Do we have adequate spaces within our newborn unit to support what is recommended within the standards? So in a nutshell, I think space is an issue. And my colleagues from NEST are here as well, and they've been trying to do something to address that, and maybe they can speak to that as well.
Thank you, Dorothy. The team from NEST, do you have a comment, remark?
Yeah, so NEST as we recognize that infrastructural challenges are one of the key barriers to quality care provision in the county. So we do have a pot of funds that, stand up? Yeah, so we do have a pot of funds that the hospitals that we support can apply to improve their physical infrastructure. And to date, we've funded about 8 hospitals. They're improving their physical layout and also addressing some of the issues that touch on staff welfare, creating additional spaces for KMC, and really. And we are doing this in guidance with a recently launched national norms and standard that I can see Dr. Imelda is here. She can speak about that. So it's actually guiding how we make these infrastructural improvements in the hospital. So we do recognize it as a challenge, and it's something that we've heavily invested in and hoping that it can contribute to addressing some of the gaps. But I think the key challenge remains the staffing across all the hospitals that we are supporting. Yeah, thank you.
Thank you very much. Now, someone just reminded me of a visit we went with them a few years back to Pumwani maternity. Who has spent a full day at Pumwani? It's a life-changing experience, right? When you see what happens there, what those doctors, nurses, and everyone, the teamwork that is there, and the workload they have, I don't think you can come out of Pumwani the same again. And this is what I mean. Something interesting happens, and we just commemorated the World Breastfeeding Day the other day, yeah? And there are these beautiful things there called milk banks. So you walk in a room, there's a mother, because of XYZ, is unable to breastfeed her baby. You walk to the next room, there's a mother who's overflowing with the milk. So how do they talk to each other and help? And it's part of the neonatal nurses' work to actually explain to this one why it's important she donates to help the other one and save a life. It's something that we rarely talk about, but how challenging is it? And what resources would it need? Because I know men who, when you're I donate maziwa, wapi? There's still a lot of stigma around it. And it falls on with neonatal nurses in those settings to sit down people and to start explaining to them why it's important. It's a service we usually overlook. I would just want to learn from researchers, what can we do to enhance some of this life-saving? Did you observe anything out there in that regard? And it's because it's something I've personally seen, especially at Pumwani, neonatal nurses actually take initiative to do it.
I'm actually not going to attempt to answer that question. I'm going to ask another question in response to that question. We have conducted very many research projects in this country, many of them under KEMRI or under the University of Nairobi. And there are many lessons that have been learned that would lend enormously to the discussion we are having here. The study may not have been about neonates or newborns, but it would have been in HIV, because the issue of scarcity of resources has an entire discipline that deals with this, called economics. Economics understands that resources are scarce, so you have to plan and manage them. What steps do we actually take to learn from whether it's malaria research, resources will be limited. Whether you are dealing with maternal health, resources will be limited. But there are always lessons learned, because there are success stories that accompany all these research studies. What do we learn from these other studies that would help us look at this particular critical issue around neonates?
Thank you.
Thank you, and probably I don't have the perfect answer, and I think Prof. Were has been around for a longer time and in the policy-making table, so I'll ask him to chime in. But from a health workforce perspective, I think a lot of what we've learned from, and maybe not health workforce, but from HIV and malaria, they were very good at speaking the language of the people who hold the money, may it be donors, may it be treasury, may it be, the patients themselves. They always presented solutions as a return on the dollar. For every dollar invested, X number of patients have access to drugs. For every dollar invested, this number of patients are screened, are tested, and onboarded for care. Unfortunately, for workforce, we haven't successfully done that. We've always said there is a workforce shortage, And we've always said we want more nurses, we want more doctors employed. But we've never, and because of the way we package that piece of information, is that everybody sees workforce as an expense. Nobody ever presents and says, if you have 5 extra nurses, this is what you get in return. You get happier patients, you get happier mothers, you get babies going home faster, you get babies spending lesser days in hospital, and therefore you save hospital resources. And I think until we speak to Treasury, who are the people who allocate how much should go to health workforce, then we can speak all day here, but we will not have an impact. So I think my reflection and ask to everyone seated here is we need to speak to the stakeholders who make the decisions. We need to make the budget-making tables in our counties so that health workforce doesn't have a budget ceiling, which is limiting counties to recruit more health workers. We need to see to Treasury so that they can see the value of allowing more money to flow to counties. In the last 3 years, the amount of money the government collects has increased, but we haven't allocated more for health workers. We still have put a budget ceiling. So I think I want to stop there and maybe ask Prof.
You put it well. This is what we call research to action. Unfortunately, researchers don't do that big action itself, but they make it available, make the information available to those who make the decision. We synthesize information like what is behind you, but that's why the health workforce has to be looked after in a manner that David is saying. But not to bypass your issue on the breast milk banks. I think they are an important inclusion in our work. Back in 1980, when I came to the newborn unit, some of you are not there. We had a milk bank in Kenyatta, and those have faded away. And I think their return is welcome for purposes of looking after the critical newborn. Thanks.
Thank you very much.
I think we should also hear from the chair of the Kenya Pediatric Association.
Yeah, both.
Okay, let me just speak about breast milk and breastfeeding and milk banking. So to start with breast milk, why it is important, I think all of us know. And one of the challenges that we have in terms of looking at neonatal mortality, and one of the best interventions in reducing the mortality is when it comes to feeding options for the baby. And in feeding options, breast milk should be, is the best. And when we look at breast milk, it's not just food for the baby. Breastfeeding as an action for the infant is actually a whole system that promotes the health of that newborn. And a system means when the baby is able to breastfeed, they get the nutrients from the milk, but beyond that, it has more health implications, reduces the cost of treating that newborn from infections by providing, an immune boosters to the infant. So there's a whole system that would go into cutting the cost of care that we are talking about. So Professor here has mentioned about costing. Maybe we haven't done the costing, but if you look at it, I don't think we look at breastfeeding as an investment for the health system, in the sense that we do not give a cost to the milk that a mother is producing and see how much they would save by just being able to produce the milk for that infant. And I'm driving to a point to say if we can invest into that infrastructure that will promote breastfeeding, even in our neonatal units, that will promote milk production, and look at it in the sense that if we do not provide that infrastructure, it means we have to spend more and buy those commercial formulas which are inferior to the breast milk. We will spend more because we didn't give the first milk to the baby, and so the baby gets exposed to infection, and eventually we are going to buy antibiotics, we are going to buy other products, and that adds on to the cost. It also translates to increased care that is needed for the baby, because then the nurse now has to take care of other complications that have been brought about by lack of breastfeeding. So I hope that is shedding light on that cost of not providing the main resource, which is breast milk. And the idea now of having the breast milk banking is essentially to make sure that every infant has access to breast milk. The best and the optimal is to breastfeed from the mother's breast, but the next best is milk, breast milk, and not other kind of preparations.
Thank you so much. Perhaps Dr. Bosire, you have something to add?
Thank you very much. I would just like to add and speak to this conversation that the way that you can judge a health system is in accordance to the quality of care that it provides to its most vulnerable members. And who can be more vulnerable than a newborn? You know, that's where life begins. The other thing that is related to that is that quite often we are pushing for family planning. But a mother cannot stop giving birth to children unless she's assured that every life that she brings forth into the world will live up to adulthood. And so these things are very connected in many different ways. So we can be speaking to the mother and say, don't bring more children into the world. But unless that mother is assured that every life she brings forth into the world lives to adulthood, then we also cannot make progress in that area. And then lastly, to speak to the economics thing, it's quite often common to have people view healthcare as welfare. And therefore, they don't see the return on investment that is required for people to be healthy. And yet, health and also education, I might want to add, are very critical to our country's socioeconomic development. Much more than any mineral we'll discover, much more than any oil or any other thing that we can invest in, much, much more than even the technology that we can invent. And so until we invest into ensuring that the people are healthy, we really cannot hope to progress as a country. And I think for those who are in economic planning, if they recognize that health is not welfare, that this is investing into the country's future. I mean, even I remember 20 years ago, World Bank saying that breastfeeding is a critical piece to socioeconomic development and requiring countries to report on their indicators for breastfeeding, recognizing that it has a long-term economic value to any country. So if we remember these things and invest in them, then we can make progress. But if we don't, and especially if we don't invest adequately in health, then even all dreams that we'll come up with, even our vision for 2030 and so on and beyond, will continue to be a pipe dream. And I think it's a message that we have to keep reinforcing in every space that we have an opportunity to do that.
Thank you very much. And thank you for telling us about, reminding us about the importance of family planning while you were at it. Because I was happy this week. I actually saw us taking family planning very seriously with cartons of condoms going to Homa Bay. So it was very interesting. Now, the chair of the Kenya Pediatric Association raised a very important thing about antimicrobial resistance. I happened to be walking along corridors at Cambridge last week, and there's a scientist who's currently doing something and has classified, I think I saw around 20 antibiotics that are not working in just one county alone they have established. So what sort of a headache does it pose to neonatal nurses who are trying to treat babies? That's something I think we should also have a conversation about. But as we think about that, there's a question from Ruby, who's the representative of preterm mothers. Huh? Preterm baby mothers. Yes, thank you. Let me come to you.
Hello, everyone. My name is Ruby Kimondo from Primila Foundation. I'm here representing moms of preterm babies. Have 4 children. 3 of them were born preterm. Actually, my firstborn, who is 22 years old right now, a final law student at Strathmore University, was delivered by the good Professor Were. I don't think he remembers. I keep reminding him. I've reminded him, but I think he's now grown old. He was very young. But he's only received my son, Leo. Leo was born at 28 weeks, at 1.3 kilos. And he had complications. We stuck in hospital for about 2 months. So we were with this guy, but almost every day. And so it was an experience. But he's okay right now. He's healthy, very sharp, very bright in law school, aspiring lawyer. So it's really a full circle moment for me, Prof. Because 20 years ago, I was this young, vulnerable mom with a preterm baby. I got a lot of support from him, but also from the nurses at the hospital. So this conversation is really close to my heart. Because as you're speaking and as the nurses stood up to speak, I remember the nurses when I was at that hospital. They're the ones who taught me how to express. And many mothers these days use breast pumps and stuff, but I was taught by the nurses how to manually express. And for all my 4 children, I always just used to manually express. I never had a problem with milk. It was, I don't know how to explain to you, it was a very surreal experience, just being held by those nurses every day, being encouraged, and learning how to take care of my baby. Such that I was only 26 years old. I'd never heard about prematurity. I didn't know how to take care of such a small, because by the time you're getting discharged from hospital, the baby is about 2 kilos. It's still a very small baby. So I didn't have skills, but I was taught, and when I went home, I was able to take care of my baby. Anyway, that's beside the point. I said this is a full circle moment because I've now come back, Prof and the team, as a parent. Just not me. I have Lynette here. Lynette is also a mom of a preterm baby who would have been 10 years this year, but she lost the baby. So we've come back as parents and we're saying we want to help. Yeah, we want to help. And we've been helping. We've been offering psychosocial support to other mothers like us. So my question to the panel, or what recommendations do you have in mind to formally recognize parents like us, parent groups like us who want to help? How can you integrate us into in the health system, somehow allow us to come in and offer this much needed support to the mothers, but also align it to the needs of the healthcare workers? I mean, from these findings, the nurses also need support, and we are able to give that support. So what specific structures or systems can be made or constructed or brought up, or policies that can formally recognize us parents who want to come in and help?
Thank you so much, Ruby. A round of applause for her. And Ruby, before you sit, we called Leo are usually very sharp. Thank you for affirming that. Yes, Professor Were, clearly this is your baby from 20 years ago. So would you please do the honors?
Better authorities to talk about how to link mothers with themselves and with the system. I could have a go. I think 20 years ago, when we had that baby, I don't know that we had social media. If it was there, we hadn't discovered it. 20 years ago, there's a very thin bit of, if nation media was there, I'm not sure, it used to function until sometime X, then it hands over to CNN. What I'm saying is that in addition to policies which you should write down, we are at a space in time where linkages are easy. Our duty here is to help you have the methodology and the messages that you can share with each other and to be available to answer questions if they come. I can say no further that we need those to happen. That is definite. You need not to be battling the one neonatologist as the only person you know scratching his black beard then, not as white as now. But it's a time when what you're saying is should have happened yesterday, and we should actually have an environment that is looking at that as being important. We have just put into law the new primary health care system, PCN, as we call it, with beautiful infrastructure from the hub all the way to the spokes, and the final spoke is the community. And all along there, the community is actually the people who are having their babies. So have we included that as a I think we sort of have, but we are saying we should refine it. And it's the duty of these findings and how to go further. How do we make sure that when you go to somewhere in Mandera, there's a mechanism by which those mothers can commune with each other, and that should be as much a business of those mothers as it is of us health workers, as it is of those who lead the professional associations that are relevant to it, as it is for those who do the primary research, as it is for the good Ministry of Health, and the other 47 departments of health that exist. I hear you. I'm now not wearing the hat of a researcher. I'm now the human being who does a bit of advocacy on the side. You introduce something that I think exists in a small way, had been made to exist through the mothers, but it's a business of everybody from the top of the health system leadership. I think beyond that, I would go to shut up. Did you want to add something from anthropology? 2 words?
One word. I'm thinking of it in terms of my role as a researcher. So we've done a lot to hear about the experiences and rightly put what more can we do in terms of testing out things with the mothers and working closely with the county governments and the ministries, and then going back to provide the evidence. This is how we did it. This is how it works in different contexts, and this is why it is. Do some costing studies as well. This is how much we would earn, or this is how many lives we would save. So thinking more towards more co-production of things and co-creation with the community.
Okay, before I go ahead, my journalistic instincts takes me to I feel you have something to add.
Well, I think your feelings are right, but I was just listening to. Okay, I've already forgotten her name, but Ruby, yes. And just to say that we sit on this side, but we are also mothers and parents. And I think another time I was sharing my own story with Dr. Dorothy here of how I delivered a small infant, and being a pediatrician. And then one day after, I go to the neonatal unit, and my baby was in the NICU, and the first thing the nurse tells me is, "We need milk." I was like, "Milk?" So I had just come out of anesthesia and everything, and I'm thinking, there's no milk, and why is my baby in the first place in the NICU? And after all that explanation, so I go back to my room, and the baby wasn't as small as maybe hers, but was small for the gestation that I expected the baby to be bigger. But that is to say that, yes, we can link up as a professional association. What we have been doing and continue to do is first do some training, capacity building for our members, but also we have gone into the space of also building capacity for our colleagues, the nurses. And if I was to just mention, we have a program where we are having a sponsorship program to sponsor nurses to go into pediatric training, pediatric nursing training. And we also sponsor nurses to do midwifery training. And the idea of that was to build the capacity, because we recognize that it's not just the doctor, it's a whole team that is needed to be able to provide quality and optimal care for the newborn. But the other step we are taking is engaging with the community and looking at it as an approach holistically, bringing in the families. And we have made recommendations of we need family care rooms in neonatal units, so that then in those rooms we can bring in the families to be able to explain, so that by the time that baby has spent a month or more in the newborn unit and they are transitioning to back home, the family needs to ensure that they provide the necessary support so that the baby can continue to thrive. But the other good key component, and in the newborn unit, my experience is we usually have other mothers who have stayed longer becoming the peer supporters of those who are now starting out. So that becomes very helpful when we link up now with organizations like Ruby's to just come in and provide support. We have provision in most facilities, and I work in a public facility, to have continuous forums where we provide continuous medical education, and there's definitely an opportunity to just invite them over and speak to our mothers, speak to the healthcare workers, and through those experiences, I know most mothers would be encouraged, because I can tell you, when you're faced with, when you see some of the babies, they're very tiny, but hearing a testimonial from another mother really encourages. And I can tell you, when I talk about breastfeeding, even that mother who was not having milk, by just hearing the story from another one, you will see it changes the whole system, and they start to produce the milk, and eventually that baby will go home. So I think we have opportunity to work together with such organizations, but also just even individually for those mothers who have had an experience in newborn units, to just encourage others.
Thank you so much. I'm glad I trusted my gut feeling. You see, this is why I always tell guys, journalists are angels. Now you've seen it for yourself, right? Thank you very much. Let me move to Lynette. Where is Lynette? Lynette, how are you?
I'm okay.
Are you breathing fine?
Yes.
We would love to hear from you. Thank you.
Hello, everyone. My name is Lynette. I came with my colleague from Primilove. I am now a mentor mom. 10 years ago, I delivered a child at 26 weeks. She was 1 kg. It dropped to around 680 grams. I was 24 years. I used to hear about preterms. I didn't know I would get one until I came across Primilove Foundation. That was under Ruby. So I had a hospital stay of 5 months. 3 months in Thika level 5 and 2 months at Gertrude's. We moved because at Thika we did not add weight as it was required, so she needed more specialized care. I just want to say that the nurses do a fantastic job, the doctors do a fantastic job, but while we're at that room of expressing, moms get so nervous when they hear the voices of a nurse. Munafanya nini? Wanatutemeka, especially the young mothers. And the nurses mean well. Have you washed your breast? Have you done this? Have you done this? So at times I feel like there is that gap which a mom who is not a healthcare profession can feel. you come and talk to moms, you come to talk to dads, because even dads are part of the process. So that is what we have been doing for the past 10 years. Because Primilove is 10 years now, because it started in 2015. We've been doing home visits, we've been doing hospital visits at Kenyatta, sometimes Pumwani, Mbagathi, and all we do is talk to the moms and tell them, we have been here, and this is how it goes. Some outcomes are good, some outcomes are bad, but we keep pushing on. I am lucky to have delivered in public hospitals. My first child, it was a mission hospital, then I got the experience of the public hospital. The issues are the same. 10 years ago and now. 10 years ago, Thika level 5, we were still sharing beds. 3 moms, our babies are in NBU, they are taken care of properly, but now the moms, you have to fight for where to sleep. But now Thika has really improved. They built another unit. They are doing well. It's not as how I was there. I delivered my second child. God is good. She was a term baby at Garissa PGH. Now there is still a challenge, and a big challenge. I don't know if your research went to Garissa. I am not sure you went to Northeastern. There is a gap. And you know in Northeastern, mothers give birth. Seriously. You're in the ward, but the mom is telling you, uni wasita, ata nazani ende. And it's serious. She can tell you. But now the issue is, how many health workers are being sent to Northeastern? How are we motivating these nurses to go there? Because the labor wards are working 24/7 in Garissa PGH. I am a CS mom. I was in the hospital for 3 days, and I would see the nurse who is at the labor ward is still coming to attend to the patients who are in the wards, and they'll still go back. And in my mingling there, because I'm a Primilove mom, I was talking to mothers. You are talking, you're sharing. There are those who have preterms. You take a walk to the NBU. But the challenge is, I think the challenge you are having in the city and what is outside the city, you need to maybe take your research outside Nairobi as well, outside Central Province. Go to Northeastern, go to Turkana. There is a gap. There is a big gap. I was lucky enough, I saw it with my eyes, but I got the care I deserved. But still, you'd see if there's this mom who is a new mom, because of the numbers, kuja kama uko karibu. You know, they are telling you, when you're feeling the pain kabisa, because they don't have where to deliver that child again. The beds are full at the labor ward. There are only 2 beds. 1, 2. The rooms after postnatal, yes. Moms are not sleeping. You're standing because now, wekeni watoto kwa kitanda. You see, wekeni watoto kwa kitanda, because you cannot allow this mom to finger this mom, and the babies need to be put somewhere. Remember, there's the CS moms, you're being told, Mama tembea. You're still there's nothing wrong with your child, but you have the experience of the preterm. So you're going to the NBU to encourage moms, reminding them, yes, I did. I cannot tell them she died. She's okay. She's thriving. They thrive. Encouraging the moms at the NBU, because that is what I do at Primilove. But at the same time, there's this other mom who is being told, tembea, but there's no space. The numbers are there. The nurses want to help you, yes. But they cannot listen to you. There's this one here who is in labor. Yes, you're in pain, but the doctor cannot listen to you. Huyu daktari amekuja ward round yake haraka anaenda. So as much as you're doing your research in the major towns, I think you need to call us and tell us, moms, come and show us. Because there are moms. We have moms in our groups who are not in Nairobi, who are not in Kiambu. They can tell you where the gaps are. Nairobi, I think people are doing well. Just leave Nairobi and go to other small towns. I delivered personally Garissa PGH, and I saw it. I was just lucky enough I got a room, because, maybe a nurse at the labor ward. So you've got a room where I could sleep with my child alone. But what of those moms who are coming and going, having complicated? You're in a room, next room, a mom is bleeding, but by the time you're calling a nurse, the nurse is telling you, sasa nitaacha hii. Paka anakwambia nisaidie kushika maji. Nikimbie, nitoe glove. Now we take up the roles. We take up the roles, which is written there. We take up the nursing roles. We are not nurses. I personally at Thika, I was feeding kids with NG tubes. I used to love doing it because when I was there was a go-slow. So I was the one telling moms, your tube imetoka, because of experience, not because I know, experience of being in that NICU for long. So we have a role to play as moms.
Thank you very much. Thank you very much. Diana?
It's only fair that we have the nurses.
Thank you once again. It's coming clear. It's becoming better than I thought. That when Prof. Gadara, we are talking about one nurse taking care of 25. This one nurse is taking care of 50 plus. And we are talking about a nurse having 48 babies in the unit. You have 96 persons that are looking up to you, one nurse. So this research is the best we have had in Kenya. Let's communicate it well. It will bring results. Thank you.
Thank you so much. Just wow. Now, there are some people, quite a number, who are watching online, and they have questions. They are part of us too, though they may not be here. So there's a lady called Lina. She's asking the researchers that she would love to know, what did you establish about nurses who give special care to Kenyans who are disabled? Because we have 1.5 million disabled persons in this country, and I have been to health facilities where they have to give birth on floors and need really specialized care. So I think...
So our actual research did not go into that side of things, so we can't give an appropriately accurate answer to that one.
Thank you. CT, you've been quiet for so long. I hope you're not thinking about Mandamano. Anyway, I have a question for you, CT. It's from the audience, from your many faces of work. Yeah, they want to know, how do we mobilize people to action?
Anytime you are involved in phase 2 or phase 3 sort of like studies, where the numbers of people are in abundance, and when you consider that most research projects in this country are conducted either among people who are resource constrained or in rural areas where resource constraint is the norm, you will find that the guide that helps you actually are the ethics that guide biomedical research. And I say this because you are told very clearly what you need to do, but now actioning what is written is what sometimes is difficult. It is difficult if you think that as a research scientist, it is you who knows everything. Research functions when you partner. I like the term you use, Dr. Lodge, co-creation. Good word, that one. When you understand that the community needs to partner with you as equals, and that the experts in the community is them and not you, and you treat their expertise with the respect it deserves and it actually needs in order to thrive, because that's its oxygen, then the community will join you. Kemri Welcome Trust do this. They know. Something they've worked on. Community engagement is something they've worked on. Now, when I worked in the field of HIV and AIDS, it was absolutely necessary. There was a term we use, it's called task shifting, where there is a remote clinic, has one nurse, one, and it's really remote. How does this one nurse ensure that those who come from that locality get their ARVs on time? And this is where now the training of people who are non-clinicians, non-medics came into being. But this one has to be tended to carefully, very, very carefully, because the thing about Kenyans is this: they have a tendency of being creative. You have a volunteer who, if you're not careful, soon becomes a doctor. And the only time they have any clinical experience is when they visited a doctor to be treated. But because they have this role in the community, they now become doctors, and now you've created harm where none existed. But task shifting and ensuring that the community embrace the project so they feel they are part and parcel of it, that is really the key. Once the community feel and understand, and the things you do, you create community boards that help you, advisory boards that help you with the process, and you ensure that the understanding of that particular study is something that is promulgated by the community, not you. The community then identifies with their own members, and it becomes a lot simpler. Now, it works better when there are very many research projects that continue going there, so that people now get to understand research. Problem is this: most people, when you engage them as community, either ambassadors, as far as they're concerned, you've employed them. If they're in the advisory board, they want you to give them a certificate or something to indicate, or badge to indicate that they've been employed. Now, this isn't bad. It's just symptomatic of the problems that we have and how our people are in need of something that they feel they can be part of. It is a process that takes time, but once the community have embraced it and understood the benefits of it as well as the harms, then believe me, the next study that comes along will be the greater beneficiary of what it is that you have studied, or started rather. And the next one, it will even be easier, because then you also have a cohort of people who actually understand research, and they are community members. The person who gave me the mic, where did you go to? Okay.
Thank you so much. That is CT for you. He can be a water vendor as well. Where's Dr. Melda? We haven't heard from Dr. Melda. I saw her somewhere. She must be hiding somewhere. Dr. Melda, how are you? Are you breathing fine? Yes. Thank you so much. I have a question for you. I don't know if it classifies as a burning one. What are the plans of reaching out to MOH with the findings, and how will you ensure that the findings of this study will contribute to what the Ministry of Health is doing? Okay. That's from Dr. Imelda. What are the plans of reaching out to MOH with the findings, and how would you ensure that the findings of this study will contribute to what MOH is doing? For example, MOH has developed the norms and standards for establishing newborn care that has organized newborn care into and highlighted the HR, infrastructure, equipment, and supplies, etc. for various levels. MOH has also developed a newborn investment case. So how are we going to basically have tangible results from your findings? Yes. So please go first. You look like Duale's bestie. So.
Thank you very much, Dr. Imelda and the rest of the team. Actually, we've worked with the Ministry of Health from the inception of this project. And so even as Kemri is a branch of the Ministry of Health, And we are very cognizant that I think it's really an opportune time for these findings when we are really building norms and standards. So we have backing from the ministry that this is how a neonatal unit should look like in terms of the floor planning, in terms of the people who should be offering service. And so in terms of our support, I must say we have received incredible support from the Ministry of Health, the Division of Neonatal and Child Health. And so I think the onus is on all of us that the goodwill is there, but remember health is a devolved function. So we now need to cascade those really good dreams and good plans and good norms and standards to the facilities and to the leadership now at the 47 counties to say, this is where the direction we are traveling as a country, how do we move together? So I think to answer your question is, we are working very close. We are MOH actually, isn't it? KEMRI is a branch of the Ministry of Health. So we are working with the Ministry of Health very closely. Thank you.
Thank you so much. So we expect you to hold yourselves accountable. That's the summary of it all. The buck will stop with you guys to ensure that everything that you've established is actionable. Interesting. Yes. Questions are coming in thick and fast. Now, findings on effects of crowding on infections and AMR. My AMR person is there. What do you think? Yeah.
Okay, yeah, the problem of crowding introduces other challenges in the NBUs, and part of this is how to make the place clean, first of all, because if you have too many crammed up, say, cots, for example, it makes it difficult for the people who are tasked to clean to do that. It also makes it difficult for mom who are providing services at bedside to their babies, because imagine a case where there's a mom, or babies are sharing incubators and they need to do things at that side. So when it's too crammed up, the space is not good enough for them to be able to deliver the care, say, feed the baby or clean their baby. The other thing also we need to think about when we talk about crowding and IPC is that there are measures that are taken, for example, to ensure that hygiene is maintained, say like the mother's gowns or the baby's linen that needs to be cleaned a certain way to make sure that it is good and it is actually protective to the babies. So when we have too much of those, we wonder, we would like to also question whether we have commensurate number of linen for the babies that are there or adequate gowns for the moms to be able to use them when they are there and they are required. There's also the aspect of supplies. For example, do we have adequate soap? Do we have adequate sanitizer? Do we have adequate gloves for the nurses to be able to do their work? So I think it's a matter of also, do we have adequate spaces to tell the moms, for example, when they come in, or to do a group training, like this is how you wash your hands when you come here. This is where you leave your shoes, for example. When you come in here, this is where you get the cup. This is how to pick a cup. Don't just touch everything. There is pictures, and all that. So this needs to be done there. And it has to do, one, awareness creation for the moms, two, the healthcare providers have a role to play there in terms of their own hand hygiene, the students as well are in the units, and also empowering the moms to be able to also contribute to hygiene in the NBU.
Thank you so much. Anyone else, Doc, on AMR?
Okay, I'll just give an example. In the facility where I work, the policy was enforced a few years ago where there's no sharing of beds. And that happens in all the wards, but also in the neonatal unit. And I'm sure the researchers here can support what I'm saying. And it has had a significant impact on our outcomes as a unit. So I think it's just an issue of enforcing the policies. So if all the county governments made that kind of a provision, it will significantly cut down the rates of infections. So yes, it's not the only intervention in reducing infections and dealing with the issue of antimicrobial resistance, but it is a great step. So just by making sure that in a neonatal unit, the baby should have their own space. In the postnatal ward, we encourage the baby to be with their mother, so skin to skin. In neonatal unit, the baby stays in one incubator, one baby, not 3 babies. That used to happen. I used to work in another facility some years ago. We used to arrange them as, of course, the smaller, then the more they fit in one cot. If they're bigger, then less, And so it's an enforcement of policies. And I think that one doesn't need more research. I think it just needs implementation.
Thank you so much, Doc. I was coming here to check on Dr. Diana's voice. Apparently, it's still one term. But, Doc, there's a question for you here, just based on your presentation. If they want to know the methodology of the study, just a summary. How was the data collected? How did you manage to be given and the observations of the study to control and the underestimation for control for over and underestimations? Then the duration of the study. Then how many nurses are neonatal trained? Yes, I find that very interesting. They're citing that a previous speaker stated they have on-job training. I was also in some facilities where there are trained staff to other units. So how many nurses are neonatal trained? I find that a very interesting question.
It's a very interesting question, John. Unfortunately, yes. I might not have a response to the numbers of the nurses who are neonatal trained, but I'll speak to the methodology that we used. And so what we did is, as Siti Muga mentioned, is that we sat in the units for the shifts, through the shifts, during the day, during the night, public holidays, weekends, just observing how care is provided. And so through work that has been done previously, we have been able to, based on how sick a baby is, have a matrix of what care that baby should receive. And so what we did is sit in, observe maybe 3 to 4 babies in a shift, and every time maybe a procedure is done, we tick, and out of that we can be able to say in a shift, this is the amount of care that was provided out of what is needed. But the second methodology, over and above the observations, is really interviews and speaking with the clinicians, speaking with the mothers, speaking with the nurses especially. But we also had what are called focus group discussions, where we have a group of mothers sitting together and just sharing experiences and us getting opportunities to learn from them. The other methodology is really interviews with the leaders of the wards, the managers, the directors of health at county level. So it's really sitting in, listening, asking questions, going back, looking at the data, come back, ask more questions. So this project has been running for about 3.5 years. So that's how long we've been in these units, just learning every single day. Thank you.
Thank you so much. I'm so happy to hear your study is older than SHA, actually. Anyway. Now, where's Claire? Please hand over the mic to Claire. Claire is representing Mr. Collins Ajwang, the president of the National Nurses Association of Kenya. So the floor is yours.
Thank you.
Yes.
I think it's still morning. Good morning once again. Good afternoon. Okay, thank you. Good afternoon. I'm representing Mr. Collins Ajwang. And if I don't pass his regards and make a comment about NNK, tomorrow he might not send me another place. So, NNK is a National Nurses Association of Kenya, and it has to heart neonates because we have a pediatrics chapter where nurses share research they have done in pediatric units, and it really encourages nurses to do neonatal nursing. And we have BLS on neonatal resuscitation, which is trained at the complex, at our head office, the nurses complex. So nurses in Kenya have the platform to come and join the other nurses countrywide who are doing research on pediatric care. We always have a conference once a year on the pediatric chapter. So it deals with research on pediatric care, neonatal, and midwives. We also have a midwifery chapter which deals with the midwives. So all that cascaded down, we take care of our units and the pediatrics at large. So nurses are into it.
Thank you so much. And are you going for Mandamano?
That is not. We are an association. We
Yes,
are not a union.
No, I'm
We have
just,
a nurses
I'm just asking
which
whether.
deliberates on that.
I know that, but I'm just asking if you are going for Mandamano. No. Thank you very much. As we wind down, I just wish to also give the opportunity to the Kenya Pediatric Association to just give their closing remarks. What next from your viewpoint and the office that you hold?
So as KPA, our mission is to promote quality healthcare for children in Kenya. And we also go beyond into the region. And one of the things that we do is promoting research amongst our membership, but also collaborating with the research organizations. We also work closely with the Ministry of Health when it comes to policy and guideline development. But at the same time, we are part and parcel of the implementers of the same policies through our membership who are distributed across the country, and providing mentorship opportunities, and especially in neonatal health. I think it's a key agenda for us, and in improving the neonatal mortality. So for us, we are cutting across and just bring also together all the stakeholders. We work also closely with the Nurses Association. There's the Midwives Associations. We have collaborated together in programs, in research, and the next step from here is implementing and translating this kind of research into action. We also have forums where we convene annually in our scientific conferences, and we do not fail to discuss newborn health. And so I know that this has been discussed already. It's a continuous conversation, and we look forward to having those take-home messages, the key messages from this research and more research that has been done into action. Because for us, we are really working extra hard to make sure that we achieve the 12 per 1,000 or even below.
Thank you so much. There's a small voice telling me to ask you whether Shah is working for babies, but I will save that one for another time. So thank you very much for being an incredible audience. I finally will wish to give this opportunity to Professor Were to just give his closing remarks. Yes.
I think I need to have closing remarks from the front line to begin with. Who would... I'll give the political one.
Thank you. I think for me it's been an exciting journey doing this work. I think having, from the inception, our main aim was we knew there was a nursing workforce shortage. We knew there was a health workforce shortage problem. And the aim was not only to admire the problem, but also provide some bit of a solution to help contribute to the evidence that, contributes to the policy decision making, why we need additional nurses. So we went in with the hope that we will put in additional nurses, and we generate evidence that more nurses equals more care being provided. While we did that, we were not very successful because nurses were taken away from the newborn units that we put them in. And that was a little bit challenging because we didn't get the full package of the intervention as we had envisioned it. But even with that, we still achieved something. We still demonstrated an additional dose of nurses. We still demonstrated that even with additional limited time of nurses, you get additional care being provided. But that care, even the additional care provided was being prioritized to very sick babies. So nurses have this difficult role and the moral ethical dilemma of how to choose who to give care to, which is a very difficult task that we give to them. And we've heard from moms and other people working in these environments that we need to give them their credit for their resilience, for their effort, for the greater work that they are doing in these extreme environments. So I think that's a very positive outcome for us and learning. Number two is that we cannot have business as usual just because someone showed up on duty, as Nancy said it. That's not enough. They showed up on duty, but they're not giving the best care possible that parents deserve, babies deserve, and which is, is their human and legal right to have that care. So we must do things differently. And there are no shortcuts about it. We need more nurses. We need more health workers in these spaces. I think the most important thing is to start having these conversations. We must acknowledge that we might not have the additional 10 nurses we might want in the newborn unit, but we must also hold our leadership that small baby steps of an additional 1 or 2 nurses makes a difference. And we demonstrated that in the units that we went through. It made a difference in the care that was being provided. It made a difference in the well-being and teamwork and how nurses felt that they had people who would relieve them of duty when they needed to. They had a chance to go and leave, which is they were able to have, mothers had better patient experiences. So I think those are very soft things that you can't measure, but are important. Thank you.
Thanks. There's some correction of vocabulary. That was the take home, the way forward. And another correction. There's no more suitable person to give the closing remark than Dr. Bosire, who is representing the institution that was home this research. And when she speaks, she can knock the other doors and pass the message. So my case, and they say nothing more, and allow my elegant old student to bring about the closure.
Thank you very much. There is a saying in my mother tongue that in times of plenty, you feed the children first. In times of scarcity, you feed the parents first, so that they can go out and look for more to bring back. If you feed the children first, then the whole family might die. And there will be no one to take care of that family because you gave the ones who couldn't even bring more to take care of the family. And as from this research, and as we are focusing on nurses, if we don't take care of the nurses, then whatever we expect from the health system to deliver to the patients will not happen. For that, we need to put in the resources that are necessary to do the best that we can, to offer the best care that we can actually offer. And some things need more resources. Sometimes it's to use better the resources that we already have, to do the things that need to be done. And so we continue to do more research, we continue to work more closely with the community, with every to do more and to see the desires achieved, where everyone can be healthy and can live their full life, to do all that they came to us to do. And so I thank you for the time that you spent listening here. I hope that you become our advocates to take the message from here to wherever space you interact with, because I see that it's not always the most senior person who knows the most influential person. Sometimes it's just an ordinary parent who who knows somebody else, and speaks the right word to those ears, and we see the changes happen. And so even as we continue to do whatever advocacy is needed from our end, you have the being present here today to speak to, and whichever space you are able to say or speak about this study. And so you become our advocate also to keep passing on the message as we move forward. Thank you very much.
Thank you so much. Dr. Diana, is your voice back or it's still one time? I thought it would be baby steps and it will respect neonates, you know. Thank you so much. Would you say something? Thank you so much. It is okay. Thank you so much, ladies and gentlemen, for this time, for also having us here. We equally learned so much. And dear researchers, when we as journalists reach out with questions even at 1 o'clock, please just drop a text. Yeah, please just drop a text. Sometimes it's very important that we speak to you guys always, but sometimes due to unavoidable factors, you'll find a journalist trying to look for you. Please, even if you're watching Harambee Stars and Zambia, just spare a few. We know where the millions will go already, but just spare some time for us. Otherwise, thank you so much. And from Nation Media Group, we sincerely thank you for this day and for being here. Thank you so much. My name is Leon. I love babies. I cover children a lot.
Make right.